Hello everyone, dear friends and colleagues. First of all, welcome of all of you to the IDF Mena Bleu Circle webinar about the topic type 2 diabetes, insulin management in special conditions with eminent speakers. As chair of IDF Mena region, it's really deep pleasure and honor for me to be the moderator of this session with my friend, Professor Hazim Abdul Razak from Iraq. Professor Sandid, who was to moderate this session, is having a personal impingement of last minute, could not join. As you know, the monthly webinar MENA region webinars that we started last year in July 2020 were very successful, and today we are at the 10th session. As part of the celebration of the centenary of discovery of insulin this year, in the world and in the MENA region, this webinar is the second one, which be organized with the Insulin Centenary IDF MENA Working Group. In this occasion, I want to express my deep thanks to all members of this working group, and especially the coordinator of the group, Professor Shabin, and also Professor Hassanin, the coordinator of MENA Bleu Circle Webinar Scientific Committee. At the same time, I would like to thank all the other working groups in the MENA region for the wonderful work they are doing, as well as all the associations in the MENA region for their exceptional dynamism. This session, which focuses on insulin treatment in special situations, will be animated by Dr. Ina Shaltout from Egypt, Dr. Hind Iraqi from Morocco, Dr. Salah Abu Snana from UK, and Dr. Shabin Naz Masoud from Pakistan. It promises to be very attractive and informative by the quality of the teams chosen and by the credibility of the speakers. As you note on the agenda of the meeting, we will have 5 minutes for patients video about interview with people with diabetes in special situations. After, we will give the floor to our speakers, 20 minutes for each lecture. At the end of the lectures, we will have 20 minutes also for discussion session with this question from attendees. I invite all participants to send their question in the box for questions. Many thanks again for all participants from MENA and outside MENA region. My deep thanks also to Amber Event and to the sponsor of the webinar, LifeScan. Thank you for your attention. You have the talk, the floor, my colleague, Professor Hazim.
Okay, thank you very much, Professor Jamal. Dear Professor Jamal, this meeting about certain aspects of insulin therapy, which would be delivered by distinguished speakers from the MENA region. Since the discovery of insulin and its first use at the years 1921, 1922, there had been a great development of several types of insulin to meet the different needs for diabetic patients. Before discovery in 1921, people with diabetes, they did not live for a long time. The most effective treatment was to put the patient with diabetes on a very strict diet with minimal carbohydrate intake, and this could buy patients a few extra years, but couldn't. The dietary regime even caused some patients to die from starvation. So the first insulin used was extracted from dog pancreas. Later, insulin from cattle and pigs was used for many years and saved millions of lives, but it wasn't a perfect one, and it causes allergic reaction for a large number of patients. The first genetically engineered synthetic human insulin was produced in 1978 using E. coli to produce insulin. And so insulin now, it comes in many forms, from regular human insulin, identical to what the body produces on its own, to ultra-rapid and ultra-long acting insulin. So thanks to decades of research, after this historical review, our distinguished speaker will discuss the use of insulin in different categories, as well as the issue of hypoglycemia and the role of self-monitoring blood glucose in insulin-treated patients.
Many thanks, dear Hazim, for this introduction. And now we are beginning our session with some patient video interview with people with diabetes in special situation. And I would like to thank deeply our colleagues from Lebanon, from Pakistan, especially Dr. Jackie and Dr. Michel for this very interesting video which were organized and prepared by in Lebanon. Thank you, Michel. Thank you, Jackie.
Hello, everyone. My name is Zaya Eid, and I am an 18-year-old type 1 diabetic patient at the Chronic Care Center. 12 years ago, I did not show any evident symptom of diabetes. Instead, I just woke up one day with severe stomachache and then woke up the next having lost my ability to see and breathe properly. The doctors at the hospital confirmed that that was a symptom of a severe ketoacidosis attack and that I was diabetic. You see, had it not been for the discovery of insulin 100 years ago, 12 years ago, a 6-year-old would have never made it out of the hospital, and I would have never been here today talking to you. And had it not been for the discovery of insulin and the very supportive families that I have, and yes, I do say that in plural because other than the supportive biological family behind this camera right now, there's a very supportive family that I am proud to be a part of at the Chronic Care Center. And had it not been for insulin and these families, we as patients would have never had the ability to get a second chance in life and figure out that there's a lot more to us than just a few non-functional beta cells. So always remember to cherish and appreciate the tiny molecules inside your body that save your life every single day without you even realizing that.
To celebrate the insulin centenary, let us all work to make it available and affordable to all those living with diabetes. And remember, to those living with type 1 diabetes, insulin is life.
38 years old, and I was diagnosed with type 1 diabetes 14 years ago. I am married, and I have 2 young boys, ages 8 and 10. So what does insulin mean to me? It's very simple. Insulin is my lifeline. It is what I need to be able to be sending this video to you today.
100 years after the discovery of insulin, and it remains not accessible to many patients around the world. Let this celebration be a call for action to make insulin accessible to all.
I'm a doctor, engineer, and associate professor in Lebanon. I have type 1 diabetes since 1989, so I'm living thanks to insulin for more than 30 years now. Insulin for me is more than just a lifesaver, it's life itself.
Many thanks for our friends from Lebanon, Dr. Shaki and Dr. Michel, for this very informative and interesting video for insulin, the discovery of insulin, the importance of insulin, and we can repeat every time, insulin is life. Insulin is the most important discovery during in the medicine in 1920. Thank you, dear Jackie and Michel. And Hazim, you can present our first speaker.
Okay,
Yeah.
thank you very much. So now may I call for the first speaker, who would be Professor Inas Sheltout. She is the president of the Arabic Association for the Study of Diabetes. She is a professor of internal medicine and diabetology in the College of Medicine, Cairo University. Dr. Inas will talk about insulin treatment in the elderly people. Dr. Inas, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Thank you very much for invitation to be a speaker in this important event. And I'm going to talk about insulin treatment in elderly people. Do they need to be treated differently? And let me start with this statement. Life expectancy has been increasing. Advances in medical care and improved social conditions led to increased life expectancy. And I come to this question, does the epidemic of diabetes involve older individuals? And the question is yes. By the year 2050, there is going to be 336% increase in the number of diabetics above the age of 75. And according to International Diabetes Federation, the flat prevalence of diabetes above the age of 20 is 8.8%, while according to the National Health and Nutrition Examination Survey, above the age of 75, the percentage of diabetes is 17 to 21%. Diabetes in geriatric times is somewhat different as regards goals of therapy, choice of drugs, changed metabolism, and danger of hypoglycemia. Carbohydrate metabolism in the elderly shows that in most studies, there is rise in blood glucose, especially the postprandial blood glucose, directly correlating with age. The fasting blood glucose increases 1 to 2 milligram per deciliter per decade, while the postprandial blood glucose increases up to 15 milligram per deciliter per decade. This is due to impaired insulin release and delayed suppression of hepatic glucose output. These are some challenges in management of type 2 diabetes in the elderly, and let me start with acute metabolic complications like DKA. They are rare, and features and management are the same like in younger individuals, but there is higher mortality due to associated cardiovascular disease. The hyperosmolar non-ketotic coma, 50% of cases occur in newly diagnosed diabetics, and they always occur in older individuals due to impaired maintenance of serum osmolarity, decreased thirst perception, and decreased access to water. Okay. Acute infection is a frequent precipitating factor in 40 to 60%, and it's usually pneumonia. There is difficulty in management due to requiring for rapid fluid replacement. It may not be feasible due to associated cardiovascular disease. For geriatric diabetics, is there a risk of hypoglycemia or not? And the risk of hypoglycemia is increased in geriatric diabetics, and it may lead to impaired cognition, which is increased in the elderly. Older adults may have more neuroglycopenic manifestation of hypoglycemia like dizziness, weakness, delirium, confusion, compared with the adrenergic manifestations happening in younger individuals in the form of tremors and sweating. These symptoms of neuroglycopenia may be missed for a primary neurological disease, such as neurological transient ischemic attack leading to inappropriate management. Hypoglycemia, which is a major challenge in treatment of diabetes in the elderly, may happen due to patient risk factors, lifestyle risk factors, or medications. The patient risk factors include advancing in age, intercurrent illness, chronic liver disease, renal disease, cardiovascular disease, endocrinal deficiency like thyroid, adrenal, or pituitary, loss of counter-regulation of hypoglycemia, and hypoglycemic unawareness. The lifestyle risk factors include poor nutrition or fasting, prolonged physical exercise, or alcohol. And the medication which can induce hypoglycemia is sulfonylurea or insulin use. And sometimes there is drug interaction with sulfonylurea. Severe hypoglycemia account for almost 17% of all hospitalization for type 2 diabetes in the elderly. Geriatric diabetes shows some unique syndromes like diabetic amyotrophy, malignant otitis externa, pyelonephritis, diabetic neuropathic cachexia, intradermal bully of the feet, periarthritis, and increased risk of accidental hypothermia. We come now to the management of diabetes in the elderly, And according to the American Diabetes Association 2021, we should consider at first the assessment of medical, psychological, functional, and social conditions for self-management abilities of the elderly diabetic, and to screen for geriatric syndromes like polypharmacy, cognitive impairment, depression, urinary incontinence, falls, and persistent pain. And at the beginning of diagnosis of diabetes, we should screen for dementia above the age of 65, then annually. There are two series for management. One series with a postprandial blood glucose goal of 200 milligram per deciliter, and the second series is euglycemia with fasting blood glucose of 110 and hemoglobin A1C less than 7%. What to choose? And according to the life expectancy and current medical problems, we should choose individual target for each elderly diabetic. According to the American Diabetes Association statement said a few years ago, although age per se should not be an excuse for suboptimal control of blood glucose, it may be neither feasible nor appropriate to achieve such tight control in older diabetics, and goals should be individualized. Again, coming to ADA Guidelines 2021, older adults who are otherwise healthy with few coexisting chronic illnesses and intact cognitive functions, the hemoglobin A1C goal should be between 7 to 7.5. Existing chronic illnesses, cognitive impairment or functional dependence, the goal should be between 10 and 10.5. We should screen for diabetes complications and to treat hypertension to individualized goal, and treatment of other cardiovascular risk factors should be individualized in older adults according to expected life expectancy. These cardiovascular risk factors include lipid lowering therapy and aspirin therapy. And this is a framework for treatment for glycemia adults, and for those healthy with few coexisting chronic illness and intact cognitive function, the rationale is long life expectancy, and the hemoglobin A1C target should be between 7 to 7.5, fasting or preprandial glucose between 80 and 130 milligram per deciliter, bedtime glucose between 80 and 180 milligram per deciliter, blood pressure less than 140/90, and statin can be taken except if contraindicated or not well tolerated. For those with complex intermediate multiple coexisting chronic illness, intermediate remaining life expectancy, the target hemoglobin A1C should be less than 8% with fasting between 90 and 150, bedtime 100 to 180, blood pressure less than 140/90, and statin unless contraindicated or not well tolerated. Very complex and poor health with limited life expectancy, avoid tight glycemic control, and no hemoglobin A1C goal is required, but we should avoid hypo or hyperglycemia. This is the same table, but a little bit more clear. And for lifestyle management, optimal nutrition, protein intake, regular exercise, and loss of weight in overweight or obese with physical activity and diet, and 5 to 7% weight loss should be considered. Difficult to adhere to strict diet due to some difficulties like financial difficulty and poor food preparation skill. No strict diet is needed. And for Diabetes Canada 2019-2018, for most adults with type 2 diabetes, hemoglobin A1C target should be less than 7%, and it can be less than 6.5% in newly diagnosed patients with no risk of chronic kidney disease, no risk for retinopathy, and no risk of hypoglycemia, and from 7.1 to 8.5 for older individuals, 7.1 to 8 in functionally dependent older individuals, and 7.1 to 8.5 in those with recurrent severe hypoglycemia or hypoglycemia and awareness, limited life expectancy, and the frail elderly, with or without dementia. To avoid higher hemoglobin A1C, to minimize risk of symptomatic hyperglycemia and acute complications, end-of-life A1C measurement is not recommended. Those are the oral antidiabetic medications, and the contraindications and side effects of most oral antidiabetic medications are like the same in younger individuals. Sulfonylurea with side effect of hypoglycemia by guanides can be used except in renal and hepatic insufficiency. Alpha-glucosidase inhibitor with severe GIT disturbance as a disadvantage. Thiazolidine-dione with the risk of heart failure. Incretin-based therapy seem to be safe with no risk of hypoglycemia. GLP-1 receptor agonists are safe with no risk of hypoglycemia, and we should take care of exenatide if the GFR is less than 30. SGLT2 studies showed that no increased incidence of side effects except for hypoglycemia in older adults. Again, Diabetes Canada with recommendations for sulfonylurea, and it's better usually to use GPP4 inhibitors instead of sulfonylurea, and the initial doses of sulfonylurea should be half those taken in younger individual, and the dose to be increased more slowly. Glyclazide and glyclazide MR and glimepiride should be used instead of glypiride. For insulin therapy, according to Diabetes Canada, DTMER, glargine, U100 and U300 and degludec may be used instead of NPH or human 3070 insulin to lower the frequency of hypoglycemic events. And it's usually better to use pre-mixed insulin and pre-filled insulin pens to reduce the dosing errors in older individuals and to improve glycemic control. Again, AGA 2021, simplification of complex regimes is recommended to reduce the risk of hypoglycemia and polypharmacy if it can be achieved within the hemoglobin A1C target. And this is the table for insulin. And again, this is either a patient with basal insulin plus or minus short-acting insulin and patients with pre-mixed insulin. For patients with basal insulin, to change the timing from bedtime to morning basal insulin and to increase the dose slowly every 2 days, we can increase 2 doses of insulin if at least 2 times increased fasting blood glucose more than 150. A little loose control, not tight fasting blood glucose control like in younger adults. If more than 2 fasting self-monitoring of blood glucose, home monitoring, are less than 80, we should reduce the dose by 2 units. For mealtime insulin, if the mealtime insulin is more than 10 units, try to reduce the dose by 50% and to add a non-insulin agent. They are encouraging use of non-insulin agents to reduce the insulin dose. And if the mealtime insulin is less than 10 units per dose, we may change to non-insulin medication, another non-insulin medication. And this non-insulin medication, if metformin is not given, we can start with metformin as long as the GFR is allowing metformin use. And if the metformin is used, we can add a second oral agent or non-insulin agent. For patients on premixed insulin, use 70% of the total dose early in the morning to reduce any nocturnal hypoglycemia, possible nocturnal hypoglycemia. And in nursing homes, when they are dealing with geriatric diabetic patients, consider diabetes education for the staff, and to give these staff an education when to be alert if any side effect happens or any complication or acute event happens, like hypoglycemia less than 70, they should give oral glucose or IV glucose sometimes, and when to ask for help if there is hypoglycemia or if there is hyperglycemia, and when to ask for the doctor, and any reading is too high for glucometer or side effects happening or complication, if the patient is sick with vomiting, with symptomatic hyperglycemia or poor oral intake. And let me finish with this summary for insulin. There may be a possible medication error due to visual impairment, impaired manual abilities in older individuals, limited access to injection site, and insulin analogs are usually preferred due to less hypoglycemia. Thank you very much.
Thank you, Professor Ines, for this very informative conference. Thank you for your talk about specific situation and the best how to use insulin and other treatment for elderly person. We will come back to discussion with the questions from attendees. Now I will present our friend Professor Hind Iraqi. Professor Hind Iraqi is currently professor in endocrinology and metabolism disease at Mohammed V University of Rabat in Morocco. She is member of multiple scientific society of diabetology and endocrinology. Her areas of interest are therapeutic alliance, growth hormone, and thyroid disease. Her clinical research interests include thyroidology, diabetology, national and international review. And Professor Hind Iraqi is an expert trainer of the diabetes conversation map. Professor Hind Iraqi, please, you have to talk about how to avoid hypoglycemia in insulin-treated patients with CVD and CKD. Thank you.
Thank you, Professor Belkhadir, for your kind introduction. And it's my pleasure to share with you this presentation about how to avoid hypoglycemia in insulin-treated patients with cardiovascular disease or chronic kidney disease. As you just see with Professor Ines Sheltout, we have to deal with specific situation, elderly, other chronic disease complications, and when we have a patient that should be on insulin, then we need to deal with different aspects. I'm going to share with you my thoughts when I was preparing this presentation, because talking about how to avoid hypoglycemia with patients with insulin therapy and we know that they already have cardiovascular disease or CKD, this is a real vicious circle. Why? Because we know, and we are going to see that diabetic patients, especially type 2, they are at risk to do these two complications. And then it's not insulin therapy. It is recommended to promote SGLT2 inhibitors and GLP-1 receptor agonists as the first-line therapy for these conditions. And when we want to lower vascular complications, we know that we should have A1C, that we lowered A1C. And when we lowered A1C, especially with insulin, then we increase the risk of hypos. So when we have patients with hypos and they already have CVD and CKD or CKD, then we are worsening their prognosis. So we know from UKPDS that 6 years follow-up data, there is a clear demonstration that there is a decline of the beta cell function that exceed 50% at the time of diagnosis. So patients are going to need insulin therapy, or they are going to be in insulin therapy because of contraindication for oral drugs. And at some points, most of the patients in UKPDS and even today, they will need insulin therapy. That's why we are talking about type 2 diabetes mellitus, and it's not the past non-insulin dependent diabetes mellitus. And we know also that the diagnosis is late, and about 20% of our patients, they already have complications when we do the diagnosis. So we are late. We have 50% of beta cells that are apoptosis, and we have already macro and microvascular complications. So type 2 is not a single disease. It's always with multiple metabolic and cardiorenal condition, with hypertension, coronary disease, heart failure, and also chronic kidney disease. So to deal with a patient with type 2 diabetes that is already on insulin and who will have these complications, we have so many. As you know, we have around 58% of type 2 that are going to develop CKD. And CKD and also HF, which is a leading cause of hospitalization and also of mortality, 2 causes of mortality. And to focus on hypoglycemia, we know that when you have a patient with diabetes without CKD, you have less risk than when the patient has only a CKD. And when they share both diabetes and CKD, then we have a bigger risk of hypoglycemia. So this topic is very important. But we know that we should lower the glycemic control and the A1C thanks to UKPDS, and we know that we can lower microvascular complication. So when we focus on only that study, we can say that the lower is the better. And with insulin, remember that insulin therapy is the most powerful agent we have today to control glucose. So most of our patients, almost 50%, are or should be on insulin because this is the best agent to lower glucose. And when we lower glucose, when we have a better glycemic control, then we benefit because we have less retinopathy, less nephropathy. But at the same time, if we lower too much, then we'll have more severe hypoglycemia. And also, we have many studies that demonstrated that when we have strict glycemic control, after UKPDS with the ACCORD Advanced Study or VADT, we know that we don't have benefit in cardiovascular disease. And especially with the ACCORD study, we have more mortality. If we focus on these 3 trials, then we can find that they have more severe hypoglycemic episodes, even if the lowering of A1C was different with these three trials, as the first one target was for ACCORD study was less than 6%, the second one less than 6.5%, and the advanced study the advanced study 6.5%. So this should not be our goals for patients with CKD or CVD. We know that target control has no effect and maybe even worse. And if you review some retrospective cohort study, it is already proved that we should not go, especially with the patient under insulin therapy, and lower A1C, because we have a mortality that is going to be increased. So we have a dilemma. Are we going to lower A1C to 7% or more? And then the patient is going to have a complication with treatments, especially hypos, but we are going to have less diabetes risk. Or are we going to have patients with 8% or more, and then we are going to increase diabetes risk and we are not going to have hypoglycemia? And we should think about all that, because the lower is not necessarily the better. And now we are going to see in practice what we should do to avoid hypos in insulin-treated patients with CKD and CVD. First of all, it is better to prevent rather than treat, and especially hypos. So let's see what are the risk factors for hypoglycemia. Professor Ines Sheltout has already spoke about older age, but we have many other risk factors that we cannot manage. We cannot change the age or the duration of diabetes or other comorbidities. We have to deal with that. So what could we do with those risk factors that can be managed? Especially education is going to help us. Education with meals that should not be irregular, about alcohol intake, also exercises, and we should also prefer certain medication, because insulin therapy and sulfonylurea are the two drugs that could provoke hypoglycemia. First of all, the first thing you should do is to individualize realistic A1C targets. And this individualization is a balance with good glycemic control and hypos and risk of hypos. And we should not be very stringent with patients that have CKD or CVD. Let's focus on this, this individualization with a patient that has no complication, just to compare them. This patient has type 2, he's on metformin because he just diagnosed. The duration is, you have just diagnosed it, so he's newly diagnosed. He has a long life expectancy, no comorbidities, no vascular complications. So then you could have a target of A1C less than 7, even less than 6.5%, because you know, even you are going to lower the A1C, you are not using drugs that are having hypoglycemia. But even if you are not on insulin therapy and you have patients with CKD or CVD, then everything is changing. At that time, they have a risk of hypos. They also have usually a long duration of the disease and the less long-standing life expectancy. They have also comorbidities, and then maybe you could go to 7% if you are not using drugs that are going to do hypoglycemia. And when you are on insulin therapy with that with the same patient, then to go to 7% maybe is too low, and you are going to have a risk of hypos. So then be less stringent, and because of this high risk of hypoglycemia due to their comorbidity, their condition, CVD, CKD, and also because of insulin therapy, then you should have a highest target for A1C. The second point is to select the appropriate treatment regimen. And the appropriate treatment regimen, of course, it is here mandatory to have insulin therapy, but we know that in that conditions, we have also other agents that have demonstrated cardiovascular and renal efficacy, and we can prescribe them with insulin therapy in that patients. So remember that even if they are on insulin therapy, if they have a CKD or a CVD, then we should prescribe. Also, if there is no renal failure, depending on your countries, here in Morocco, we cannot prescribe SGLT2 inhibitors in patients with the renal failure, but maybe it's going to change, and maybe it's already changed in your regions. So we could associate these treatments. So we are going to lower the glycemia without using more and more insulin therapy. So first, because we have CVD, because we have CKD, then we should be cardio and kidney centric, like it is written and demonstrated in the ADA and in the other consensus. And when we need to prescribe insulin, then we have different formulation, and these formulation have different risk of hypoglycemia. We have insulin that could cause more hypos, and also we have treatment regimens that are doing more hypos. Let's focus on treatment regimen. Here, you can see in that study, UCAPDS, then when you are using only basal insulin, of course, we are having more hypos than the patients who has oral drugs. But if you consider and compare basal insulin alone and basal plus prandial insulin, then you see that the patient on basal insulin alone, they were less likely to experience an episode of hypoglycemia than those on multiple injections. So less injections is better for that patients. And in another study that compare multiple daily injection regimen with only one injection, you can see that we have more and more hypos when we have more and more injection. You are going to tell me then, okay, doctor, but with only one basal insulin, it's very difficult to lower the A1C. Yeah, I agree. But if you want to lower the A1C with less hypos, like Professor Sheltut said, you should avoid using NPH and prefer those new analog insulin that are having less hypoglycemia. And here you can see with the Glargine U300 that we have less hypoglycemia, and also with degludec. And how could we lower the A1C with patients on insulin therapy? We can use the combination if you have in your countries. They may be combined or not, but it is very interesting to combine basal insulin with a receptor agonist, GLP-1 receptor agonist, especially because you have a patient with CKD or CVD, choose the liraglutide, who demonstrates in the leader study superiority for, comparing to placebo to lower the 3-point MACE. And with that, you are going to lower the glycemia. Of course, you may have hypos because of the insulin therapy, the basal insulin therapy, but this analog have less hypoglycemia, and you are using another agent that is going to help you to lower the glycemia without increasing the risk. But the most important point is the third one. It's the communication. Communication is key, because prevention and non-pharmacological strategies may be the first who could decrease the risk of hypoglycemia. We should, as I said, set the appropriate glycemic target. Then education, educate the patient, educate the family on signs of hypos. And also, please, you should ask the patients to do and to use more glucose monitoring, and also to explain why it is important for the patient to do more glucose monitoring, and also the meaning of A1C, because these CKD and CVD patients, they are a high risk of doing hypoglycemia. So especially with the patients who experience a lot of hypos, they may not report typical symptoms. So with increasing the blood glucose monitoring, or also considering CGM, then it could be interesting to recognize hypos. And we have many studies that demonstrate that when you have an intensive and individualized education, you could decrease hypoglycemic events in patients with type 2 diabetes. When you have these patients who has a standard education and an intensive education, then they may have less hypos. And also, they may have less hypos, and they may be more interested in their situation, and you would have more adherence to hypoglycemia management with that kind of patients. So to summarize and my calls to action are, please, it is better to prevent than to treat. Education. Glycemic goals should be individualized. That's your job. You should explain also that to your patients. And then if you are on insulin therapy, please consider fixed dose GLP-1 receptor agonists to simplify treatments and also optimizing A1C control. Then, with GLP-1 receptor agonists and with gliflozin, SGLT2 inhibitors, then they are recommended for that patients. And to finish, education is key. Education is key. Education is really the key for these type 2 diabetic patients with CKD or CVD, if you want to have less hypos. And thank you very much for your attention.
Thank you very much, Professor Iraqi, for this interesting talk about hypoglycemia in insulin-treated patients with chronic kidney disease and cardiovascular disease, and the ways to overcome it. Now, the next speaker would be Professor Salah Abu Snana. He is the head of Diabetes and Endocrine Services in Sharjah University Hospital. He is also a member of the British Endocrine Society and several other diabetes and endocrine associations. And his talk would be about the role of self-monitoring blood glucose in insulin-treated type 2 diabetic patients. Dr. Abu Snana.
Hello, thank you for the introduction, and thank you for inviting me to be with this such a fantastic program. So my job in the next 20 minutes, I'll be talking about the role of SMBG in insulin-treated people with type 2 diabetes. Those two pictures, one of them is the University Hospital where I do my clinical practice, and the other one is the University of Sharjah where I do my academic work and research. Those are my disclosures, nothing related to this presentation, and my flow of presentation will be some introduction to set the scene, then I'll talk about the guideline standards, then talk a bit about the interpretation and implementation of SMBG. I'll have a few slides about Ramadan, as Ramadan Kareem is approaching, and I will have few slides at the end for CGM, which we use quite frequently in my clinic. And just to make the scene easy for the frontliners of the patient care to be able to use this, although I've been asked not to talk too much about the technology, and I'll concentrate more about the SMBG. Then I will summarize and conclude. So when it comes to the SMBG, we have to keep in mind it's an educational tool that should be used in conjunction with diabetes management action plan. So you can't use that separately. So very important, okay, when we do this, that should include the patient in education when it comes to the technique and targets. Again, we have to give them a specific recommendation when it comes to the frequency and timing. So hyperglycemia and hypoglycemia pattern need to be identified, and that's the aim of the SMBG. And again, the results with additional educational as appropriate need to be given by the healthcare professional during the follow-up. So we have to make sure that we ask the patient to show the SMBG and to discuss that with them and make the appropriate plan dependent on the SMBG, of course, other factors as well. Here are some general principles for the, if you want to implement the SMBG. So if you ask who should use it and who should not, just as a general principle, all patients who have diabetes should perform SMBG. And again, but when it comes to the need, that's need to be individualized between patient as most of our management plan and targets. The other thing, when we talk about the SMBG, it should be used by the patient and healthcare professional for both of them to be able to make decisions for the management plan. And again, it won't be cost effective if simply we perform the SMBG without taking action based on the results. That's very important point we have to keep in mind. Patient with diabetes, of course, like any other patient, they have rights to know their glucose level. So there are barriers as everything in life to improve the outcome with the SMBG. So for example, if they access the supply, the availability of the supply, again, the cost, whether the insurance, they're going to approve it or not, even if it's paid out of pocket, it's quite expensive. Sometimes there are language barriers when it comes to the language available in some of the glucometers, and the adherence. Very important factor, the education, very important. And again, the technique, just simple thing by asking the patient to alternate the sites can make a huge difference. Frequency and time of testing, adjusting diet and medication in response to SMBG profile, all those will lessen the barriers for using the SMBG and make the outcome beneficial. So when it comes to SMBG in general, there are a considerable number of patients fail to use their glucose meter properly. And the common errors like failure to store the strips properly. Again, sometimes there's insufficient blood, although most of the glucometers today, they work with very minimal blood drop. No controls, out-of-date solutions, out-of-date strips. Again, failure to set meter code to match strip code sometimes happens, and some of patients come with that error. Failure to clean the optic surface of certain meters, again, one of the common user error we see in the clinic on daily basis. So why we doing the SMBG? We need to use that to create profile. And when it comes to creating profile, it's the summary and like brief account or record, and also an outline or contour. So we have, when it comes to the goals, we have to establish the pre-prandial and post-prandial target. Again, when we record the data, the way we record the data when it comes to blood glucose, medication, meals, daytime, it will make, the format will make that easy for us to assess the relationship between the above factors. And again, when we record the data in the logbook or using the memory function of the sum glucose meter, we have to adopt which one it's easier for our eyesight to come up with the simple explanation and profile. And again, we have to facilitate the pattern management, so we don't look at the outliers when it comes to the readings. So let me just briefly show you some of the standards from the American Diabetes Association and from the Association of American College of Endocrinologists. And what I'm trying to show you here is the monitoring only, so I'm not going to discuss the other standards. So when it comes to the glycemic goal for ADA, A1C goal is less than 7%. When it comes to the preprandial, 80 to 130 milligram, and postprandial, less than 180. ACE is more stringent, where the HbA1c is 6.5 and below. Fasting is less than 110, and postprandial glucose is less 140. When it comes to the inpatient setting, it's different with the acute care and critical care. Acute care is 140 to 80, and critical care 110 to 140. Those goals, with keeping in mind those targets can be individualized according to the clinical scenario and patient presentations. So when it comes to the frequency, the ADA suggests that for those who they are on multiple insulin injection or pumps, they have to do prior to meals or snacks, bedtime, prior to exercise, hypoglycemia, and prior to critical tasks such as driving. And SMPG is a useful guide for less frequent insulin injection and non-insulin therapies. When we prescribe the CGM, we have to ensure that we receive ongoing instruction and evaluation, plus follow-up to adjust the therapy. So if you have data and you don't use it, that will be really useless. So very important to make sure that we should plan our management accordingly. Here are whether they are beneficial or not when it comes to blood glucose control and HbA1c differences. Those are the randomized trial in type 2 patients who are not using insulin, which is not the subject of this talk. But those are the outcome of those trials, which is talking about the impact of self-monitoring of blood glucose and the management of patients with non-insulin treated diabetes, which is open label group randomized trial. And the number were 453 in total, and the average HbA1c is 7.5, and the reduction is 0.17, wasn't significant. So for those who they don't use insulin. Here are non-randomized trials for type 2, but using insulin, so at least a trial, and they consistently showing relationship between SMPG and A1C reduction, but not all randomized, of course, and many with flows. And still A1C reduction range is 0.16% to 0.88%, significant in all cases. So the difference here, as the title of this talk, is those people with diabetes and they are insulin treated, using SMPG make the difference, and it's quite useful. For those who they not using insulin, I showed you the randomized. Here are the non-randomized trials and meta-analysis and reviewers. But in general, although there was a conflict, but when it comes to the glycemic control and decreasing the risk of hypoglycemia, were quite significant. So they are useful. Now let us talk about the interpretation and response to the results. So when you have results, you have to act on. So pattern is very, very important, and we have to have a systematic approach to identify the glucose pattern and to determine the management in general to optimize the blood glucose control. So what's really important and what should be incorporated in the pattern is that we have to identify whether there is a pattern or not. We have to analyze what factor might affecting that pattern, and we have to take action when it's necessary. So 5 steps, okay, of pattern management. You have to establish pre and post meal glucose target. We have to gather the parental data to create a glucose profile, and we have to analyze the lookbook for a trend and find out patterns of that trend and assess what our factor might affecting this. Then if we have the 4 or 5 steps done, then we can take action. So when it comes to identifying and analyzing, okay, out of range glucose reading taking at same testing each day, for example, hypoglycemia above target reading on 4 of 7 days, and hypoglycemia below target reading on 3 out of 6 days. So we have to say, well, it's not outliers, it's there, it's significant, it's repetitive. Then we have to look at what are the influencing factors, need to look at them and evaluate them. So is the factors are consistent with the schedule, for example? What should be responsible for the out of target reading? Is it illness, stress, medications, exercise, or activity or diet? So you'll be able to identify if there are outliers or something or a new thing happening that what's the existing factor might lead to that. So then we have to take action based on what we found in the SMBG. And the important thing here to ask yourself question is it change necessary? So is it consistent of the schedule being established? Isolated value above target, maybe not a long-term threat. And we have to look at respond to the patterns. So preprandial and fasting hyperglycemia, we increase the basal, the postprandial hyperglycemia. Usually we increase the preprandial insulin. Hypoglycemia, whether it's generalized, isolated, whether it's pattern, we have to adjust the insulin or adjust dietary carbohydrates intake. So based on that, you'll find your action is very easy to take. Okay, so A1C, it's postprandial and fasting plasma glucose. So postprandial plasma glucose affected by the preprandial glucose, insulin secretion, glucose load from meal, and insulin sensitivity in the peri and peripheral tissue. Fasting is the hepatic glucose production and hepatic sensitivity to the insulin, and both are important when it comes to the blood glucose control, but the fasting more when the blood more toward the diet control, and postprandial more when it comes to the hyperglycemia. Very important, okay, that the risk of hypoglycemia, we have to identify who are vulnerable. So elderly population, for example, because of the food intake, decrease of renal function, decline, you see a risk of hypoglycemia. That's like erratic eating and erratic timing of meal and renal impairment. All these are a risk factor for hypoglycemia. And the rule for SMBG in hypoglycemia, documentation of glucose level, is extremely important. Hypoglycemia symptoms do not always correlate with very low glucose level. And SMBG is a critical tool for decision-making process to determine through glucose levels. So let us talk about Ramadan, and I'm sure there will be lots of talks about Ramadan. And that's the recommendation for the blood glucose measurement. It says either pre-dawn meal, morning, midday, and mid-afternoon, and sunset meal, and 2 hours after iftar, and at any time when there is symptoms of hypoglycemia are recognized. This is, of course, the decision of who's fast and not to fast. This is not the subject of this talk. However, even those who we ask them not to fast, they have to, because they will be either very high risk group or high risk group. So they have to monitor their blood sugar frequently. And those who they are moderate or low risk, which they can fast the SMBG 1 to 2 times a day, and all patients should break their fast if the blood glucose less than 70 and blood glucose more than 300, symptom of hypoglycemia or acute illness. So blood glucose target in Ramadan, before sahur, it's 120 to 140, midday 140 to 180, pre-iftar 70 to 110, 2 hours after iftar is 180 and below. This is for the exercise, which is talking if patients want to do exercise, the target should be between 100 to 140. Snack first if the blood glucose below 100, of course, that's out of Ramadan. So the last item in my talk is the technology. So this is the blood glucose monitoring. So what you can see here, BGM 4 times. And if you look at those white circles, you see it's all within target of If you apply CGM, what you can see, there's highs and low. So BGM only provide measurement at single point in time, which is mean high and low can go undetected, as it's shown on this. So you have two highs, hyperglycemia, and you have 2 or 3 hypoglycemia, which can go undetected if we use only finger prick. This is again 3 different patients. HbA1c are sort of not all the time create equal, because here the HbA1c for patient A, B, C equal. However, when it comes to in target range, 100% for the patient A, 63 for patient B. In fact, when it comes to patient C, they are 18% into hypoglycemia. So this is the importance, what's the time and range can provide when you know, and that's provided by the CGM. So although as most of the other techniques, glucose meters got limitations. So asymptomatic episodes of hypoglycemia may go unreported, and that's critical. So in cohort of patients with type 2 diabetes, almost 50% experience hypoglycemia even over a 5-day period. Or of those patients, 75 experience at least one asymptomatic hypoglycemia event, undetected hypoglycemia, and that's limitation. So when it comes to the innovation and technology, accurate CGM technology available for a person with diabetes, and it's being prescribed, and we do that on daily basis in my center. Also, only 52, we have to make sure that those patients with diabetes, we are not achieving the target. So it's 52% of our patients achieve the target we talked about at the beginning, which is 7 or below, and 20% of adolescents, 30% of adults with type 1 reach the A1C goal. So I think we should start when it's available. Of course, for those who are not available, we have to stick to the SMBG as much as we can. But if we have CGM technology available, we have to prescribe it. But what's more important is we have to standardize the CGM metric and personalize the diabetes management, and that helps a lot in personalizing the management. So what I'm going to introduce to you is the ambulatory glucose profile, and that's like a tool to standardize visualization of CGM data. Because what's happened, if you look at the ECG, it doesn't matter what's the machine being used. If you look at the X-ray, if you look at the MRI, always you see the same picture. So it's very easy to make the interpretation. So AGB is constructed from a model of day plot, which collapse glucose data over several days or weeks, plotted according to time as if they occurred over a 24-hour period. So you see this. You see the median, and you see the plot of the summary of the 14 days you see in the upper graph. This is what you see on the AGB report. So you see the metric and targets, and you see the AGB profile for 14 days. And you can look at the profile and say whether the patient in the target, whether there's fluctuation, and you can look at the individual day through the daily views. Let me just exclude the first 2 bars of this graph. So what you can see on the metric values is the time which used in the day, so 13 days in this patient. Number 2, the percent of the CGM is active, 99.9% active. Then you can look at the average glucose, glucose management indicator, glucose variability. And you can look, of course, on the time range on the right-hand side from 6 to 10, where it's either very high target range, or low or very low. And that's really easy for you to have a look and make a plan, and you can look at the profile and you can see the fluctuation in this patient. So let us just give you 4 examples here. So what you want to see basically is when you look at the profile, you want to see flat. So that's mean there is no fluctuation, and narrow. So that's close to the target, as in a range that's lie between the 2 lines. So let us see the first one. What you can see in the first one, definitely it's fluctuating. So it's not flat and it's not narrow. You can see the distance between the percentile, the top and the below one. then it's not a range. You can see the two lines, which is show us what the range target is, and it's not. So this is not flat, not a range, and sorry, not narrow and not a range. If we go to patient number 2, so what you can see, it's flat, not narrow, not a range. So this is much better because now you can make a plan. It's easier because it's flat. Then patient number 3, it's a flat and narrow, but not a range. So what you need to do now is just to get that range. What you want to see in every patient, the profile is a flat, narrow, and a range. So just again, to go through this again, it's like what you want to see is flat, narrow, and a range. And there are 4 different patient profile here. So if I show you this, okay, the top one, if you look at the A1C, 6.7, 6.7, 6.7. There are 3 different patients. When it comes to the coefficient variant, and that show the variability, the excursions, okay, how much the patient fluctuate. What you can see, it's only 26% in the patient number 1, and 42 and 53. Then when it comes to the time range, 83% of time for the patient number 1 range, and only 69 range for patient number 2, and 51. And what those patients using when it comes to the technology, the first patient who they have less fluctuation and only 1 time hypoglycemia, and 83% of time range, that's the hybrid closed loop. And when it comes to the second patient who's 6.7, 42 coefficient variation, and 6 times in percent is in hypo, is 69 range, is the insulin pump, and the last one is the insulin injection. So you can see with the technology what we can offer our patient. So this is bring me, Mr. Chairman and colleagues, to my summaries and conclusions. The SMBG is a valuable adjunct to the use of A1C target in achieving glucose or glycemic control, previous real-time feedback, provide the real-time feedback, detects abnormal glycemic profile, facilitates appropriate medication management, act as both an educational and motivational tool. SMBG should be performed at various times of the day if fasting and preprandial SMBG are controlled, but A1C is above target, postprandial glucose control should be emphasized. SMBG is an educational tool that should be used in conjunction with diabetes management action plan, including patient education technique, specific recommendation on frequency and timing. And again, hypoglycemia patterns should be identified, and we have to use that as additional tool when it comes to the education. With that, I would like to thank you very much, Ramadan Kareem. Thank you.
Thank you very much, dear Dr. Salah Abu Snana, for this very informative conference. And now we will give the talk to our last speaker, Professor Shabin Naz Masoud. And it's a pleasure for me to present Professor Shabin. Professor Shabin is a professor in Pakistan, and she graduated the Dow University of Health Science with doctorate in obstetric and gynecology. She is also member of advisory board of Pakistan and serving as executive member in the academic committee Society of Obstetrician and Gynecology. Actually, she has serving as chairman of Insulin Centenary Working Group of IDF Mena region, and I would like to thanks deeply for her wonderful work. Professor Shabin Naz Masoud, would you please talk about impact of insulin treatment on maternal and fetal outcomes? You have the floor.
मेरी शादी को ना 15 साल हो गए, मेरे ना 6 बच्चे ना फोत हो गए, यही शुगर के मसले की वजह से। अभी ये 7वां बच्चा है मेरा, चौथा चल रहा है मेरा। ये भी यही मसला हो रहा है, अभी भी शुगर का मसला हो रहा है, पहले भी शुगर की वजह से कोई 8वें महीने में बच्चा गया हुआ है, कोई 7वें में, कोई 6वें महीने में चला गया बच्चा।
Thank you, Professor Jamal. It's a privilege to be introduced by you, and thank you for that kind and very elaborate introduction. And I think I am privileged to be part of Insulin Century working group, and I'm thankful to you to place your trust on me. And I think the group is working very nicely, and I'm thankful to all the group members. And we just saw a video, and that is a very heartbreaking video. I don't know whether it was not played nicely. I think we should play it after my talk finishes. The situation is very gloomy, in fact, as far as gestational diabetes mellitus is concerned. So with this, I would like to start my presentation as the topic has been very kindly said by Professor Jamal, that the impact of insulin treatment on maternal and fetal outcomes. There is no conflict of interest in my presentation. And we can see that hyperglycemia is one of the most common medical condition the woman suffers during pregnancy. And they keep on suffering because there is no agreed definition. There is no agreed definition. There is no agreed screening and diagnostic criteria. And with the increasing prevalence of diabetes, this GDM is increasing, and now it is reaching to the proportion of 20.4 million women. They are suffering from diabetes in pregnancy, according to IDF. And prevalence of hyperglycemia is increasing with the increasing in age. So my points of discussion will be about the history of insulin, when to start insulin, effects of different types of insulin on perinatal and maternal outcomes, and appropriate dosage and timing of insulin to address obstetric and perinatal outcomes. So this is, as we all know, that this is a century, insulin centenary. 100 years have passed since the discovery of insulin. So it is an opportunity to reflect on the advancement of diabetes care in the past 100 years, and an ambition for the next 100 years to strive to defeat diabetes and manage hyperglycemia in pregnancy. Insulin treatment to achieve a better obstetric and perinatal outcome has evolved significantly since 1920s as far as scalability, flexibility, reduced weight gain, and availability and low risk of hypoglycemia and inconvenience and simplicity is concerned. It has now become more convenient to use insulin than what it used to be 100 years back. So before the advent of insulin, the outlook for mother and infant remained dismal. Maternal mortality was 50%. And those who did survive, they died during pregnancy and half over the next 2 years because of tuberculosis and other complications. And the rate of pregnancy loss was more than 40%. To the extent that the father of obstetrics, Dr. Joseph D. Lee, he stressed that pregnancy should be terminated if complicated by diabetes, as the maternal and fetal risks were too high. And the dismal situation was that most obstetricians supported D. Lee's recommendation those days. Now this Jocelyn, the famous Jocelyn clinic we all have heard about, it was the first American to specialize in diabetes. And in his diabetic manual for patients and for the physicians, which was published in 1919, he said that no diabetic boy or girl should get married until they are ready to face the problems of diabetes with a smile. He further said that marriage involves no danger for men, but parturition does involve danger for women. And he further advised that two diabetics should not marry and have children. So the discovery of insulin, then the start of journey towards saving and improving lives, began in 1921. 100 years ago, a diagnosis of type 1 diabetes or hyperglycemia in pregnancy meant certain deaths, perinatal, maternal, and child mortality. We all know this picture. This is Leonard Thompson, the first person to receive insulin. You can see the difference only after few weeks. Women played a key role in the early clinical trials of insulin therapy. This 11-year-old Elsie Needham became the first person ever to survive diabetic ketoacidosis. And this Elizabeth Evans Hughes, one of the Benton's most famous patients. At the age of 15, she weighed only 45 pounds. And with the same situation as you saw earlier, Thompson's Leonard. And Elizabeth arrived in Toronto on the request of her mother, and she was injected on insulin. Elizabeth survived and later had several successful pregnancies. You heard earlier what Jocelyn was saying, but in its fourth diabetic manual for the mutual use of doctors and patients, he included a picture of Mrs. R.G. Elliott, and she is with her both the sons. She was a diabetic at the age of 24 years, and when the second son was born, she was kept on insulin and died by Jocelyn, who initially first discouraged 10 years back before the discovery of insulin and advised against pregnancy. So over the last 70 years, since the discovery of insulin, the pregnancy outcomes in terms of perinatal mortality in women with insulin-dependent diabetes has continued to improve. But in developing world like us, with the increasing rate of diabetes, cultural beliefs at odds with insulin injections, and prohibitive cost. In addition to these fears, once on insulin, always on insulin, they still prevail. Misbeliefs, less knowledge or no knowledge, difficulty in usage, storage problems, and above all, the prohibitive cost. The recorded history of diabetes in the past 200 years is essentially the story of recognition of adverse effects of hyperglycemia on both mother and fetus because of these reasons. So to achieve pregnancy outcome in the diabetic women that approximates that of a non-diabetic woman, St. Vincent's Declaration was signed more than 30 years back. Another declaration, Colombo Declaration, was signed for the same reasons, but still, if we look at the meta-analysis published in 2017 only, 100 studies showing significant association of pre-existing diabetes and adverse pregnancy outcomes, we see the same preterm delivery, large gestational age, perinatal mortality, stillbirths, cesarean section, neonatal hypoglycemia, and NICU admissions on rise. Then non-existence of pre-pregnancy counseling, and hyperglycemia at conception is associated with risk of congenital malformations. And this study was a population-based cohort study, was done in 4 million women, and you can see that the risk of major congenital anomalies in women with pre-existing diabetes kept on rising with the increase in HbA1c. So what is the relationship of lifestyle in obstetric and perinatal outcome? We all know that lifestyle and diet are must, and they should be the starting point before starting the insulin therapy. So if we look at the retrospective review of maternal and fetal outcomes in women with gestational diabetes mellitus, there is no significant difference between weight gain, hypertension, and preeclampsia. Excessive morbidity was reduced in the group receiving insulin plus lifestyle at the same level as for women receiving lifestyle modification only. And there's no difference in the p-value. Likewise, retrospective review of perinatal outcomes in women with GDM, there was no significant difference. You can see the P value in the group when the number of large for gestational, macrosomia, birth weight, Apgar score, and neonatal hypoglycemia was concerned. So so we must concentrate more on the lifestyle management, and insulin should be started only when the lifestyle management fails, because maternal complications are associated with insulin therapy in spite of all the goods that insulin has delivered to improve maternal and fetal outcome. We all know maternal hypoglycemia and increased weight gain are the complications of insulin. So is dysmaturity, neonatal hypoglycemia, and metabolic problems in the newborn. So the question is that when should medical therapy be started in a woman who is suffering from hyperglycemia in pregnancy? So the standard of care is to start the medical therapy whenever the fasting blood glucose is more than 95, 1 hour postprandial glucose more than 140, and 2 hour postprandial glucose levels more than 120 milligrams per dl. Now the question comes about the metformin if it comes to the oral hypoglycemics. To switch from oral hypoglycemic agents to insulin prior to conception is what is recommended. But do not shift oral hypoglycemics once the woman has already conceived, because the rationale is based on the fact that it may take some time to determine the ideal insulin dose prior to critical time of embryogenesis. So continue with the metformin and do not immediately change it for insulin. Though we know that insulin is a drug of choice for the treatment of hyperglycemia during pregnancy. And we also know that insulin does not cross the placental barrier as against the oral hypoglycemics and glucose and insulin and glucose and free fatty acids. So use of insulin to combat hyperglycemia for a better pregnancy outcome needs an insulin which has better postprandial control and trends towards lower risk of overall major hypoglycemia, and for a better pregnancy outcomes as far as fetal loss and congenital malformations are concerned, and should have lower peak glucose concentrations. Now the question is that there are different insulins, as we all know, and these different insulin therapies which are used in pregnancy do not seem to affect obstetric and perinatal outcomes as far as they are in the pregnancy B category. So if you look at the regular aspart listro, the short-acting insulins and the analogs as compared to the long-acting insulins, there is no difference. Effectiveness of different insulin therapies on HbA1c levels in type 1 pregestational or in type 2 pregestational diabetes, there is no difference in HbA1c, whatever insulin was used. And if we look at the long-acting insulins like Detimer and NPH, if they are compared in type 1 diabetes or in women with type 2 or GDM diabetes, we can see that there is no difference. The p-value is insignificant. There is no difference in the perinatal and neonatal outcomes with Detimer if we compare it with NPH insulin as far as median birth weight, gestational age, Apgar score, or NICU admissions, and neonatal hypoglycemia is concerned. Looking at the maternal factors, major hypoglycemia during pregnancy was similar with insulin Detimer and NPH insulin. If you can see that, daytime and nocturnal, they were almost the same incidence. And same was true for minor hypoglycemia during pregnancy with Detimer as well as with NPH. So, however, insulin aspart, which is a short-acting analog, may be especially helpful in women with hyperemesis, which is very common in pregnancy in first trimester, or gastroparesis, because they can be dosed after a successful meal. The action starts within 5 minutes. So if she has a successful meal and is effective for postprandial glycemic excursions. So the important thing is that to have a good perinatal outcome, requirements of insulin regimen, combinations and timing in pregnancy needs modification. As pregnancy progresses, we know increased fetal demands for glucose is there because glucose easily crosses placental barrier, and the progressive lowering of maternal fasting and between meal blood sugar levels increases because of continuous glucose transfer to the fetus, and the risk of symptomatic hypoglycemia increases. And to control postprandial hyperglycemia, upward adjustment of regular insulin leads to interprandial hypoglycemia. So any insulin adjustment or any insulin regimen in pregnancy requires combinations and timing of insulin injections quite different from those that are effective in non-pregnant state. So we cannot just procrastinate that, okay, whatever is good for a non-pregnant subject is good for a pregnant subject as well, or will work better. So in pregnancy, it's not only the regimen of insulin, but also the doses of insulin. And we have seen, and as you saw in the video, short video that was shown, that inappropriate dosage can be as bad as having no insulin. So begin with a dose of 0.5 to 1 units per kilogram per day according to the period of gestation. And if the woman is excessively obese with a high BMI, 2 units per kilogram is also recommended. Out of this total dose, a smaller proportion of total daily dose is basal insulin, should be less than 50%, and a higher proportion that is more than 50% as prandial insulin, because it is the postprandial hyperglycemia which leads to fetal macrosomia. Another very important thing to remember is the insulin requirements in all 3 trimesters. In the first trimester, the insulin requirements are likely to decrease by 10 to 20% because of increased insulin sensitivity and nausea and vomiting of pregnancy. But however, in the later trimesters, they are likely the requirement of insulin is likely to increase by 2 to 3 times because of increase in the placental contra-insulin hormones. But beware, if insulin requirement ever drops after 24 weeks of pregnancy, that calls for that is a warning sign for a failing placenta, because there are only 2 situations known, either a failing placenta or a failing kidney, that can so the fetal surveillance in pregnant women needs to be increased if the requirement of insulin falls anytime after 24 weeks, and particularly in the 3rd trimester of pregnancy. So in the end, this is one of my last slides. It's not only the regimen, it's not only the dosage, but the glycemic targets are more strict and to achieve better maternal and perinatal outcomes. So SMBG monitoring has very nicely been elaborated by our previous speaker, and that should be pre and 1 and 2 hours post meal and at bedtime. And pre-prandial, bedtime and overnight glucose should be between 60 and 99 milligrams per DL, and the postprandial peak should never go beyond 130 milligrams. And HbA1c may be aimed less than 6% if the woman does not have significant hypoglycemia. So in conclusion, insulin has revolutionized the obstetric and perinatal outcomes. The different insulin therapies used in pregnant women do not affect obstetric and fetal outcomes. It's actually the poor glycemic control prior to and during gestation, which is associated with poor obstetric fetal outcomes. So do not go for advanced or analogs just because they are there. Consider the economies and consider the affordability of the woman, especially in the resource-constrained settings. And any insulin regimen, type, and dosage for pregnant women requires combinations and timings of insulin injections different from those that are effective in a non-pregnant state with strict glycemic targets. With this, I thank to all participants. Special thanks to the chair of the session, Professor Jamal Belkadir, and Professor Hazim, Dr. Hasnan, Dr. Michel, and Dr. Jackie, Dr. Hasnan for arranging all this Blue Circle Insulin Centenary webinar, Michelle and Jackie for the contribution of their very nice videos, and all members of Insulin Centenary Working Group and Amber organization for their excellent coordination, and in the last but not least, LifeScan for their sponsorship. So with this, I thank you once again for your patient listening. Thank you very much.
Thank you, dear Professor Shabin, for your nice presentation. Thank you for all what you do for us, in the working group for Insulin Centenary Group. And now we open the discussion, and with my colleague Hazem, we are asking our speakers. We have some questions about from attendees. Do you want to begin, Hazem?
Okay, Jamal. I will start with the first question from Zaya from Pakistan. He is telling that he is an IDF certified diabetes educator. His question is, a person who is recently diagnosed with diabetes, his A1C is 7%, and now his fasting plasma glucose is less than 110, and random blood sugar is less than 140. Is he have any chance to reverse the diabetes?
Recently diagnosed with diabetes, hemoglobin A1C 7, fasting 110, random less than 140.
Yeah.
Is he have a chance to reverse the diabetes or not? If there is overweight or obesity, and we can reduce the weight by 7% from the baseline weight, we can achieve a period of euglycemia, and the patient can take metformin to help also. So it's recommended to reduce weight if there is overweight or obesity, and to take metformin and exercise 30 minutes 5 times per week. Then we can live as if non-diabetic for a long time, maybe years, but the patient should take care of repeated blood glucose monitoring for a fear of getting higher blood glucose at any time.
Maybe a bariatric surgery may have a greater chance of producing sometime a permanent recovery from diabetes, type 2 diabetes.
Because there should be morbid obesity, Dr. Hazem, to think about bariatric surgery.
This is on this assumption that if there is obesity, the body mass index is greater than 35. Exactly. Okay. The other question, what are the, also from Zaya from Pakistan, what are the guidelines about GLP-1 in the treatment of type 2 diabetes?
Professor Hind.
Thank you. You have many different conditions where you can prescribe the GLP-1 receptor agonist in type 2. The first one is if your patient is in the secondary prevention, he has already done an infarctus or CKD or CVD. And this is the first case. And then you may also propose it for patients who are in primary prevention, but who where you would like to lower weight and to avoid hypoglycemia. Then this treatment is suitable. It's not only for secondary prevention or high-risk type 2 diabetic patients. You could also have it in primary prevention without other cardiovascular risk factor, but your purpose is the weight and also to avoid hypoglycemia.
Okay. The other, can I go, Dr. Jamal, or you want to?
Yes. Go ahead.
Okay. The other question is that a diabetic patient on oral medication, his GFR falls to 20. How to introduce insulin in case of CKD? Should we start with basal and then add prandial with time? Or can we start with basal bolus? And what dose?
Yeah, this question is very practical, and I will suggest the people who are in the organizing committee to do also clinical cases, so we can explain specifically these questions. So when you have a patient who should begin insulin, then the first thing is not to make him an hypoglycemia. So the regimen you are going to prescribe depend on his A1C. If the A1C is very high, then of course basal insulin may be not enough. So first, if you have no emergencies, then you are not supposed to lower the glycemia from 4 grams to 1 grams. Just start with 10 units, and then the most important thing is to titrate and to increase the doses. If if you have A1C that is not very high, then you can, and you have no hyperglycemia after the meals, the postprandial, then you could begin with basal. And if you have a huge difference after the meals for the glycemia, then you should begin by a basal plus, not a basal bolus at the same time. Otherwise, you are going to increase the risk of hypoglycemia. And for the dose of the bolus, it is also recommended not to start with a high dose. 4 units of rapid insulin or human or analogs is interesting at the main meal.
Don't you think, Dr. Hind, is that using rapid-acting insulin is better choice than using basal to avoid hypoglycemia in such a patient? Especially his GFR is around 20. This is almost end stage.
In such a patient, yes, you can. What I'm always saying to doctors is that every patient is different. So and there is no only one best regimen. We should try one. You may try with only rapids, and in that case, it's human rapids are suitable. If you are going to begin only with human rapids, it depends on your glycemia in the morning. If it's very high, then you could also have basal insulin, and then you should do blood glucose monitoring and then titrate. We can have 2 patients with the same GFR, with the same weight, but they are not going to have the same sensitivity to insulin, and then you may have different doses. So for that case, in my country, these patients are managed by specialists. These patients with GFR who is less than 25, because then we can try a regimen, and then it may not be suitable for him, but we should explain to him what are the risks, also what is how he could deal with hypoglycemia, and then
محمد محمد نصر الله مش بيرد علي. طب حضرتك فاكر هو
so yeah,
someone
I would
interfering, no problem.
I would suggest to begin very slowly, depending you want to begin with basal or with bolus. Here we usually ask people to have a basal, and we use in pH2 here in that condition, and then we titrate with the glycemia.
Okay. Other question. Can you please advise on insulin regime for elderly patients on pig feeding? I don't know what he means by pig feeding, following CVA or advanced dementia. I don't know what is PEG. Anyone?
Professor?
Yes. This is abbreviated.
Me too, Professor Hazem. I don't know what's pig feeding.
stick feeding
following
yeah, it seems to me that this patient is receiving IV fluid or some form of enteral feeding through a nasal post-nasal tube, possibly.
The first question, does this patient needs insulin or not? According to if the blood glucose is high, the fasting blood glucose exceeding 250, or repeatedly the random blood glucose more than 300, or the hemoglobin A1C is more than 10%. If not, then the patient can start with oral, which is usually easier than insulin in administration. Again, if this patient is having cardiac comorbidity interfering with some medications, some oral medications, or if having chronic kidney disease with low GFR, or having liver disease, who needs insulin. So this patient, the condition should be more clear. And if the patient will need insulin eventually, we can start with a simple regime like mixed insulin, 70-30 twice per day. We can start with the larger dose in the morning and the smaller dose in the evening, and to use the insulin pen as recommended, and to increase the dose gradually as required.
Yani it seems to be that this patient, he is very critical. So I think starting insulin in such a patient, it should be very low, and then to go very slow, because he is very critical and he is very liable for hypoglycemia. It's only here important to avoid the severe hyperglycemic excursion. I think maybe a modified sliding scale is a good option for such a patient.
There
Any
is
comment? Okay. The other question, when it becomes absolute contraindication to DP,
to do any dental treatment,
for patient, for diabetic patient, absolute contraindication to dental treatment, any dental treatment for diabetic patient. What does he mean?
Treatment of the teeth, treatment of his teeth, professor, has maybe he needs some teeth surgery or extraction or something. There is no contraindication to dental treatment, except if the blood glucose is very high, if the blood pressure is very high, if the patient is having bleeding tendency, or receiving anticoagulation. So it's not related actually to the diabetes. If the diabetes is, the control is allowing the surgery. If the surgeon will accept the blood glucose level, it's not very high, or the hemoglobin A1C, sometimes the surgeon refuses to do operation while the hemoglobin A1C is high, or if the random blood glucose is high. So this patient should control the blood glucose, and if there is no other contraindication, he can go for any dental treatment.
Which insulin ideally used in type 1 diabetes? Analog or something else? Dr. Hind?
The question
which insulin ideal in type 1?
Yeah, if it is the patient is not going to be under pump, then basal bolus with analogs like Glargine 300 or Degludec for basal, and rapid analogs is better. In our country and in many countries, the cost is important. Here we try to convince the patient to have the analog, basal analog, and then they have rapids, human rapids for free in our hospitals. So we can deal also with that with the patients, but the best regimen for them would be analogs with basal bone.
Okay, again, one question for you, Dr. Hind. I would like to ask Dr. Hind about the doses of insulin before and after dialysis to avoid hypoglycemia.
Yeah, because we should prevent hypoglycemia, especially the first 24 hours after dialysis. So the patients should be treated with basal and or rapids. Premix are not very indicated in that case, and they should lower from 10 to 15% the dose of the rapid analog that is just before the dialysis, and also to reduce by 25% the dose of the basal analogs of the whole day. And even if they do that, they should do more SMBG to see exactly what is going on for their glycemia.
Another question to Professor Iraqi. She mentioned that combination of diglodic and liraglutide to avoid hypo in type 2 diabetes. But the company mentioned that in most of its study with this combination, patients with type 2 have severe hypoglycemia, less than 54, mostly with percentage above 22%. I don't know about this information. What do you?
Yeah, I don't know if the information. Yeah, I don't know if this information is right exactly, but it is proven with all the studies about with GLP-1 receptor analogs and combined with basal insulin, depending with the degludec or another one, that we have less hypos. It's not more hypos. So, and the percentage of 22, I really don't have it. It's always less. It's a very nice combination. I would recommend the doctor to ask the delegate from the company and to precise his number.
Yes, I may comment on this subject, is that they are always telling when you add GLP-1 receptor agonist to insulin or to one of the SUs, then you have to reduce the dose of insulin or SUs in order to avoid hypoglycemia. So probably the one who asked, he meant this.
Yeah, of course, but usually when you have the combined, then it is a first prescription. When it is a first prescription, if you have SU, then you have to lower the dose. But if you are going to prescribe this combined treatment at the first, then and they compare with other treatments, there is not more but less hypos and severe hypos. Thank you very much for your comments.
Can we associate in treatment of type 2 diabetes in chronic kidney disease, DPP-4 inhibitor plus SGLT2 inhibitor plus glinid? What is glinid?
Glinides.
Glinide.
Yes, glinide maybe. Plus basic insulin.
Yeah, we should do the differentiation of CKD, which is a chronic kidney disease, and renal failure. Of course, if you have no renal failure, then you can use drugs, but for your patients with the CKD, you could use all the drugs. If you have renal failure, and I think this is the point of the question, then you can use DPP-4 receptor agonist with different dosage depending on the GFR, or you use linagliptin because there is no renal elimination. You could, depending on your countries, use SGLT2 inhibitors, but if you have renal failure in Morocco, you cannot have SGLT2. We are waiting for the change in our legislation, our authorization. and glinids also, because they the main elimination is by not by the kidney, and basal insulin, of course, but these are for treatments. Sometimes it is better to have then a basal plus maybe, or a basal insulin with GLP-1 receptor agonist. Then you could lower the glycemia better than with DPP-4 and glinids. So this is possible, the association is possible, but you may have 3 oral drugs with a basal insulin, and this is a very costly treatment.
Yeah. Other question, home management of patients, please. What did he mean by home management? I don't know. Dr. Inas.
It's very...
what is home management?
Yes, it needs a diabetes book, actually. So,
okay.
Okay.
Is better for reaching control for patient with CKD to use short-acting insulin or basal insulin as monotherapy? This is
just
yes,
this, yeah,
the one which we talk about.
Yeah, we talk about, but when you have CKD without renal failure, then the best one is basal insulin, and then add in rapid insulin if you have only CKD without a renal failure.
Yes, but he's asking as monotherapy.
Yeah, you know, there is no studies specifically on one bolus therapy or rapid in type 2 diabetic patients. We have this in the case you mentioned, because they have chronic kidney disease with renal failure, so the absorption is going to be different. But usually for type 2, then you have insulin resistance, you have higher glycemia during the night, so the basal insulin is more suitable. So all the recommendation as monotherapy would go through basal basal insulin, and the only situation is when you have renal failure with GFR less than 15 or 20, like the first one, where we could use the rapid acting as monotherapy.
One question from Sharif Salim is telling that also in Egypt, a SGLT2 inhibitor are not used in wide range in CKD. Maybe all are waiting the DAPA kidney study.
Yeah, we are waiting too.
We will wait again. Okay. What is the recommended insulin regime for patients on dialysis?
Yeah, as I mentioned, plus basal.
Same answer. Yeah. What are the causes of asymptomatic hypoglycemia and how to manage?
The problem of asymptomatic hypoglycemia is when you have studies, even with sulfonylurea, and you do CGM and you see all the glycemia, then you find that many patients that are treated with sulfonylurea or insulin have asymptomatic hypoglycemia, and the more they have hypos, the more they're not going to have the signs, because of the adrenergic control that is not going to be proper. So that's why I said that it is better to prevent hypoglycemia, because when you have hypos and then another hypo and another hypo, then you you may not have the signs because of the adrenergic hormones, and if also people are on beta blocker, it's the same in English.
Blocker.
You know, like blocker. Yeah. So for cardiologic purpose, then they may not feel the hypoglycemia signs.
يعني hypoglycemia and awareness, it comes under this heading of asymptomatic hypoglycemia. And this would occur specifically in type 1 diabetes and also in very chronic, long-standing type 2 diabetes. After a very long time, due to very poor control, they would end with hypoglycemia and awareness.
Especially when they experience a lot of hypoglycemia, then there is no, is not the same.
Exactly. What are the best types of insulin used during pregnancy? And if lantus insulin or premixed insulin can be used during pregnancy? Dr. Shavin, this is the first question to you.
Yeah, thank you very much. The best type of insulin that is to be used in pregnancy is the time-tested one, regular and NPH. But if the affordability is not an issue, then Detimer is said to be safer in pregnancy, and so are the short-acting analogs, that is aspart. So this has been there has been quite a few studies there. So, but the best thing is to use insulin, regular insulin, and NPH during pregnancy.
Yeah. Okay. Hypoglycemia in elderly in Ramadan, is Rhizodic a better option for patients on premixed biphasic insulin, premixed dash or biphasic insulin? Yes. So is Rhizodic is better option for patients?
I can say any preferred insulin is better during Ramadan. There are studies about Rhizodic, but other medications are also safe during Ramadan, like mixed analogs or basal bolus insulins. The problem with elderly is to take care of hypoglycemia or hypoglycemia unawareness, or if these patients are living alone or taking high doses of insulin, this is the problem. And the type of insulin is not really the problem when we are taking the analogs. It's better usually to take the analogs, not the human insulin, if affordable.
But it is reported, although it is very expensive drug, it's reported that because it is very long-acting insulin, then its hypoglycemia risk is very, very low. It is even comparable with glargine 300.
This is a study done, but not all the mixed analogs insulin did studies during Ramadan. So I have to compare if we are having different studies on different mixed analogs, then we can choose which one is better. Maybe you have some experience with Rhizodic, Dr. Hazem, but we don't have this experience in Egypt with large number of patients taking Rhizodic during Ramadan.
Is there data on efficacy or hypoglycemia better with Rhizodic? Same answer.
Yes.
Nothing more. Okay.
And there was a question about hypoglycemia and awareness.
Now, one question. My question is why hypoglycemia doesn't appear to be that much dangerous if woman is not pregnant, while it is lethal during pregnancy. Is there any factor that causes it? I didn't catch it. Dr. Shalbin?
Yeah, thank you very much. Actually, as I showed in my earlier slide, that glucose easily crosses the placental barrier. There is a facilitated diffusion of glucose from mother to the fetus. Now, what happens that if there is hyperglycemia in fetal milieu, then this hyperglycemia is toxic to fetal DNA and can lead to congenital malformations in fetus and macrosomia if it happens later on in pregnancy. So therefore, control of blood glucose in mother who is pregnant is more important, because we have to deal with two people, mother and the fetus. So we have to take care of hyperglycemia in mother. This is more important as compared to the woman who is not pregnant, because if you do not take care of it, there are likely chances of perinatal mortality and morbidity in the form of congenital abnormalities, macrosomia, stillbirth, or perinatal deaths. And in women, and this child, not only it ends here, but this child who is exposed to this hyperglycemic milieu, when it becomes adult, it may suffer from obesity, diabetes, and metabolic syndrome. So such is the importance of controlling the blood glucose in mother.
Dr. Shabin, may I ask you how the newborn is more prone, the newborn of a lady who was receiving insulin during pregnancy is more prone for respiratory difficulties during pregnancy?
Is more prone for?
Is more prone for respiratory difficulty after birth?
Okay. That is also because of the poor glycosylation of hemoglobin, because as I said, that placenta is responsible for the transfer of oxygen from fetus to the mother. So because of the poor glycosylation of hemoglobin, this respiratory difficulty may be there in fetus because of the poor release of oxygen across the placenta to the fetus. And this fetus, on the face of it, seems to be big and huge in size, but actually it may suffer from surfactant deficiency and may result in respiratory difficulty and distress immediately after birth.
Don't you think that this is due to high level of insulin in the circulation of the fetus that will lead to surfactant deficiency?
No, unfortunately, it is not so, because as I said earlier, that insulin does not cross the placental barrier. It's the endogenous insulin which is produced by the fetus itself, and that leads to greater utilization of carbohydrates and proteins, and it leads to the big baby. But it does not interfere with the respiratory problems in the baby. So it's more with the maternal hyperglycemia and big grown baby and deficiency of surfactant that leads to respiratory distress, but not because of the endogenous hyperinsulinemia in fetus itself.
Another question to you, Dr. Shabin. Is it so difficult to reach the targets in pregnant ladies?
Sorry, can you say that again?
Is it so difficult to reach the targets in pregnant ladies?
Actually, it is not difficult to reach the targets in pregnancy. The difficulty is on the part of the physicians, treating physicians. The dosage is not adequately maintained, and at times it becomes brittle. But then when this control of diabetes becomes brittle, then in that case, multiple dose of insulin may be given rather than the conventional 2 times doses. So 3 times prandial insulin is necessary if the target, if the achievement of the target is difficult. Otherwise, it's the fear with the treating physician that she may not develop hypoglycemia, and that hypoglycemia may not affect the fetus, which is not true. So the only thing required is the appropriate understanding of the dosage administration and the dosage calculation in pregnant women. I have seen many of the prescriptions in a 70 kilogram woman. If insulin is required, she is being given 3, 4, or 6 units of insulin. So how is that going to control her hyperglycemic state? So it has to be according to the weight and should be distributed in 2/3 and 1/3 dosage, and maybe in 2 doses or maybe in multiple doses, basal and bolus ones.
Again, question to you, what best basal insulin and short acting regular insulin for pregnant ladies?
What is the best?
The best basal insulin and short-acting insulin for pregnant ladies.
See, the best basal insulin so far, Listro and Aspart, both have been studied, the insulin, short-acting insulin analogs, and there have been many studies about Aspart. And in practical, I mean, this is a practice recommendation as well, that Aspart is one of the best insulin if the cost is not a consideration for the woman, because Aspart starts acting within 5 minutes of injection, and those women who are suffering from nausea and vomiting of pregnancy, if they are given regular insulin and if she throws up, then she is likely to develop postprandial hypoglycemia because the insulin is already there. But in case of Aspart, if she has a successful meal and she can be dosed later after she is able to retain the food. So it acts quickly, and postprandial peaks are better controlled with Aspart. Having said that, if the affordability is an issue, then regular insulin R is also a better option in pregnancy. As far as long-acting analogs and long-acting insulin is concerned, then NPH is the time-tested insulin, which is really good for pregnant women. And if again the cost is not a concern, then Detima has been studied in pregnancy and is considered safe to be used in pregnancy.
Again, a question to you. What is the most important lifestyle change one can do to prevent the use of insulin in the future or for future pregnancies?
Sorry, I didn't get the question, Dr. Hazim.
I am too. What is the most important lifestyle change one can do to prevent the use of insulin in the future or for future pregnancies?
Okay, that's a very, very
for
important.
patients with gestational diabetes.
Yeah, that's a very
after recovery. Yeah,
I understand. That's a very pertinent and important question. You see, if the woman is suffering from diabetes during pregnancy, pre-existing diabetes, obviously she will continue as a diabetic woman later on, even after delivery. But in women who develop gestational diabetes, that is diabetes during pregnancy, she is likely to suffer type 2 diabetes in the next 5 to 10 years. And the prevalence and the likely chance and the risk is more than 50 to 60%. But if this risk is to be avoided, two very important interventions which are required is to control the weight postpartum and should try to bring the pre-pregnancy weight or lose the weight. And the second most important intervention will be to have at least 2 years of interpregnancy interval. So she can then avoid the chances or the risk of developing diabetes from 60%. Still, she runs the risk of developing type 2 diabetes in future, but the risk may be reduced by less than 20%. If she takes care of her weight and if she takes care of her interpregnancy.
Question to you, Dr. Hind. The effect of insulin on growth hormone secretion and normal growth of diabetic children. Effect of insulin on growth hormone secretion.
Yeah. When you have children with normal growth hormone secretion, just to
effect of insulin on growth hormone secretion and normal growth of diabetic children.
Yeah, when we have children and we suspect a growth hormone deficiency, then we can use insulin test to see if there is a high level of growth hormone, because insulin theoretically is going to higher the rates of growth hormone, but it was suspected to do at one time some kind of cancer, but now it is for sure that insulin is completely even Glargine U100 because it was suspected. There is no reason to have fear with that kind of insulin. It is, and if it's the children is a type 1 diabetic, then he has a lack of insulin secretion. Then the insulin is going just to be at the right state and is not going to higher the rates of growth hormone.
Okay, thank you very much. I think we are too late. So
sorry, Dr. Hazim.
I will
was
leave
thrown
the
away
floor
by
to
the...
Dr. Jamal. Okay,
Yes.
Dr. Jamal.
Thank you. Thank you.
Thank you.
Thank you very much. At the end of the lectures and the discussion, I would like to express my deep thanks to our speakers. Many thanks also for all participants from MENA region and outside MENA region. My deep thanks also to Amber event and for the sponsor of the webinar LifeScan. Thank you, dear Professor Hazim, for your participation with me in moderating this very instructive and informative webinar. Thank you for your attention and see you later in the next webinar, inshallah.